able to see it طبعا.
Yes,
السلام
go ahead,
عليكم
Dr.
ورحمة الله وبركاته. Thank you, Dr. Omar, having me for this meeting. And thanks also for Dr. Al-Jawhara for her effort. Actually, I'm talking about one of the common problem, and it is just to highlight about issues for neonatal arrhythmia. It will not go deep for all the arrhythmia that recognize in neonate, but at least to highlight the most common problem that we face in neonatal arrhythmia. So just at the start, I want, as any start to know, do we deal with sinus rhythm? So the sinus rhythm, it will come from the SA node to the AV node, bundle of His, bundle of branches, then Purkinje. So to give the beat that it will appear in the ECG, and to correlate it between the impulse conduction and the ECG, this is the sinonodal sinoatrial node. It will go to the AV node. So it is a B wave, then the BR interval, then it will give the QRS morphology, then which is the depolarization of the ventricle, then the repolarization will be the T wave. So the BQRS is the atrial, B wave is the atrial depolarization. We are not seeing the atrial repolarization in the 12-lead ECG, in the surface ECG. QRS, it will just highlight for the ventricular depolarization and the T wave for the ventricular repolarization. We are different in pediatric population rather than the adult population. So patient at age of 1 day had a different rate than the adolescent, than the child. But in general, we are getting one equation, which is 220 beat per minute minus the age by year. So is not as surprised that you will find patient if he's sick or he has if he has an just distress to find his heart rate reaching the 200 to 110. But if it is normal sinus rhythm, it is acceptable. And this, I like this ECG all the time, although she is not for a neonate, for a kid, she is a 10-year-old, was complaining, seen in a primary health care, stable, but when they did the ECG, they get all of them panicking and just refer the patient to the hospital with ambulance. But if you look carefully for the ECG, it is sinus rhythm, positive B wave in QRS, positive in lead 1, negative in AVF, in AVR, and positive in AV1, in AVF. So just look at this one. I'll go back to it. The speed, it was 10 millisecond instead of the speed of the standard speed, which is 225 millisecond, millimeter. So it will give you almost double the real rate. When we corrected the rate, the speed, this is her ECG. So it is a sinus rhythm with normal rate, and the issue only was a technical issue by for obtaining a good 12-lead ECG. Back to our subject, I will talk about incidence of neonatal arrhythmia, types of neonatal arrhythmia, bradyarrhythmia, and tachyarrhythmia. The incidence of neonatal arrhythmia as a benign, it is 1 to 5% of all the neonate. Non-benign arrhythmia is account to less than 0.3% of all neonate. Life-threatening arrhythmia are very rare. This is just a paper, just highlight an 18-year experience from a single center for incidents of non-benign arrhythmia in neonatal intensive care. And as you can see, they conclude that it is as low as 0.28% of arrhythmia and can be managed successfully in that period. Pharmacological management of cardiac arrhythmia in fetal and neonatal period, it is crucial because we have limitation in the access, limitation if immature myocardium. So the pharmacological therapy is the standard care for neonatal arrhythmia rather than the intervention, and rarely we are forced to go for intervention for neonatal arrhythmia unless it is intractable and failing medical therapy, which is very, very rare. And if you are lucky, just you have a fetal medicine service for cardiology. You are lucky just you will get an impression about the fetal arrhythmia. So you will plan you will plan the type of delivery. You will plan the place of delivery, and of course management of fetal arrhythmia during pregnancy. This is just highlight the fetal arrhythmia as a diagnostic value. So going to the types of neonatal arrhythmia, as we mentioned, benign arrhythmia, either it is a premature atrial contraction, premature ventricular contraction, or junctional rhythm, sinus arrhythmia, sinus brady, and sinus tachycardia, and all no clinical significant and should be no treatment. This is just to highlight about the premature atrial contraction, and it is unrecognized B wave occur with the previous T wave, and the QRS complex has the same morphology. This is for the premature ventricular contraction, and as you notice, it is the premature QRS complex without a preceding big wave indicate the premature ventricular contraction. This is just it's highlighted as neonatal brady, but it is sinus rhythm with normal axis, positive lead 1, negative AVR, positive AVF, and this is just also to be considered as a sinus rhythm rather than sinus tachy for the age of those patients. It's a little bit tachycardic, but it's still within normal. So the bradycardia, as we mentioned, it is a sinus brady. And by the way, sinus brady these days are increasing, especially with the gynecologists are liberal of giving giving good sedation during delivery. If you go for atrioventricular block, either it is a first degree AF block, second degree AF block, complete heart block, or pseudo 2-to-1 block. And this is malignant and associated with long QT syndrome. I will share some cases that may some of the audience know these cases. This is I will start by 4-day-old girl with non-identical twin. Birth weight is 2.4 kilogram. Incidental finding of significant bradycardia. Stable vital sign apart from heart rate of 55 beats per minute. Transthoracic echo showed normal function and structural heart. And this is the ECG. You can notice that it is significant brady, narrow QRS morphology, fixed RR interval, B waves more than the QRS, more than the QRS or the V waves. And also you can notice that what we call it, B wave is marching through. There is no relation between the B wave and the QRS, and this is what we call it complete heart block. And in this case, I will usually they pass their neonatal period safely, and usually they need just a follow-up and waiting for timing of pacemaker implant, which will be indicated later according to the symptoms, according to the average heart rate, according to the cardiac function. Second case, actually, this a little bit burning case. This is a 32 weeks premature baby for prima gravida with birth weight of 1.1 kilogram, known to have bradycardia, and it's a complete heart block. This is by fetal echo. So C-section delivery for maternity cause done for this lady, and the baby required ventilation for respiratory distress. Transthoracic echo showed normal heart function with large patent ductus arteriosus, left to right shunt, and good function. The issue is the weight, and you can see here cardiomegaly, although the just part of it is, as you notice, is a thymus shadow. But the ECG, the average heart, the ECG, the heart rate is around 45. Luckily, this baby is stable. Just we have two issues: either to go for pacemaker implant for this kid, or to just conservative management. Luckily, we're able to pass this kid the stage of his prematurity without a pacemaker, which is okay, but sometimes it might be difficult for him to pass this stage. So the other option, either to go for, if you have a surgeon, to put a temporary epicardial pacemaker till they grow up, and then to put a permanent pacemaker later when just they are in a good weight, because erosion in this area, it might end the story of getting him good place for basic. The only option is epicardial for him. So we were lucky, but it doesn't happen all the time. If you are in a place that there is no surgeon, and you may go for as much as possible to increase the heart rate with inotropic support. But if you or percutaneous pacing, which I find it not an easy job, but it comes for the importance of the fetal echo to decide about the place that you will deliver this baby. This is the third case is a full-term girl with fetal diagnosis of 2 to 1 block with normal vaginal delivery. She is a prima gravida mother. Vital signs within normal. ECG was done and considered to be 2 to 1 block, and baby shifted to ward with mom. Transthoracic echo within normal. 24-hour Holter was connected to measure the average heart rate for this kid. But this is the ECG, which is very concerning. You notice that there is 2 to 1 block, but you can notice the B wave, the T wave in between the two B waves. So this is the first B wave come at the refractory period of the previous beat. So this is because of prolongation of the QT of the T wave. QT is prolonged, so this is pseudo 2 to 1 block. This is alarming sign, and patient he need to be very careful, and this baby is in danger and should be considered seriously. So this is exactly what happened to this kid. 14 hours later, after Holter monitoring attachment, baby collapsed with wide complex multifocal tachycardia, required resuscitation and DC shock. As I mentioned, do you still think this diagnosis is a simple 2-to-1 block? Of course, no. This is the difference between the simple 2-to-1 block. You will find, just to make it easy equation, just you will find the B wave, QRS, T wave, B wave. This is weak conduction system. Then another B wave is conducting, but this one, no. It is this B wave. It come at the time of the repolarization of the ventricle. So failing to repolarize to conduct another beat. So this is pseudo block, while this is simple 2-to-1 block. So this is what we receive, the Holter showed for this patient. You can see it is multifocal ventricular tachycardia with torsa depot, and just because of bradycardia. And this ECG it showed prolongation of the QT interval, plus another phenomena, which is what you can notice it here. It is T wave alternance, which make it more serious issue for this baby, and required immediate action for him, which the best and simple action for him to put a pacemaker, epicardial pacemaker for her to able to avoid bradycardia, and to give to be liberal of giving non-selective beta blocker, which is the best propranolol at this stage. And this is just an example how the pacemaker is not epicardial pacemaker in the neonate is not an easy task. You can notice that here is the migration of the pacemaker to the abdominal pelvis, because she's a small kid, and this is one of the complication of the epicardial pacemaker. Now I will go to the other side, which is the neonatal tachyarrhythmia. Neonatal tachyarrhythmia, either it is supraventricular tachycardia or micro tachycardia, either atrioventricular reentrant tachycardia, AVRT, and it is either it is manifested accessory pathway or Wolff-Parkinson-White syndrome, or concealed accessory pathway. The other part is atrioventricular nodal reentrant tachycardia, AVNRT, and this is very rare in the pediatric, in the neonatal period, and almost it is reported cases. Permanent junctional reciprocating tachycardia, this is a misnomer, or PGRT. This is a misnomer of an accessory pathway with long RB tachycardia, and unfortunately, most of those cases are missed. Most of these cases are missed during neonatal period, because the heart rate usually is not high, and it will come later with the impaired ventricular function. Same thing for ectopic atrial tachycardia, and the third subject, third or the fourth part, is the junctional ectopic tachycardia, or what we call it JIT. JIT, it is two parts. Either it is a post-congenital cardiac surgery, it is malignant, but the good thing, it is self-limited. Or congenital JIT, and those congenital JIT is one of the nightmare cases and very difficult to treat. Macro reentrant tachycardia like atrial flutter, and the third part is the ventricular tachycardia. This is just a sketch to show you how the ECG will appear in different types of tachycardia. It's difficult to go through all these, but we'll share some cases of tachyarrhythmia. I will start by this case, which is 31-week baby post C-section delivery because of fetal distress and tachycardia. The heart rate variable between 180 to 240 beats per minute, stable in ventilator, Transthoracic echo showed normal cardiac structure and mild depressed ventricular function. This is the ECG for the 12-lead ECG. You can notice, you can notice here more than B waves. Just I can say it is 2 to 1 tachycardia. Give me the diagnosis of atrial flutter, but to confirm it more, give adenosine. Adenosine, it will show the sawtooth appearance, and the best management for this patient is synchronized cardioversion, and usually it is enough treatment to convert him to sinus rhythm. You may give him a follow-up once after 3 months for the function and for the ECG. Some cardiologists and electrophysiologists, they elect to give beta blocker or digoxin, but personally, I am not giving if it is if he respond to cardioversion from the start. This I get it from one of the monitors for patient with high frequency ventilator. You will notice this one, and you will find it a lot in the cardiac monitor. This is just it is artifact. This is not flutter. This is not fib. This is artifact because of the oscillator. You may do 12-lead ECG to confirm it, but even with the 12-lead ECG, you will find artifact with the oscillator. Second case is 1-week-old boy admitted through the emergency room because of jaundice for phototherapy. One of the smart residents noticed during his stay, there is no change in the heart rate, and it's fixed around 180 all the time. Otherwise, no concern. So obtained a 12-lead ECG, and he is right. This is abnormal focus of the B wave, negative in the QI in the lead one, positive in AVR, maybe bystander in AVF. So it is an ectopic atrial tachycardia, and the transthoracic echo showed normal cardiac structure and function. Esmolol was started, then later amiodarone infusion via femoral central line. Baby was discharged after 2 weeks on oral propranolol and maintenance dose of amiodarone. Unfortunately, we were able to control the rate, but not the rhythm. He stayed in follow-up up to 2 years with no improvement despite of 3 medication, propranolol, amiodarone, and digoxin, and echo showed moderate depressed function. So at this time, his weight around 12 kilo. We decided to go for electrophysiology study and ablation. And this is what we face. We face just thrombosed femoral veins, which make our life difficult during the ablation. And the reason that the reason for this is overuse and of the femoral veins for the infusion during the stay of the neonatal period. I like to highlight this point for my colleagues in the neonatal intensive care as well as the pediatric intensive care unit, that avoid as much as possible to give, if you have patient with neonatal arrhythmia, to avoid to use the femoral vein side, especially the right side. And if you want a central line, maybe you'll go for internal jugular vein to reserve this one for future intervention. And luckily, we able to find the focus in the left side with successful ablation, and patient discharged home without medication. This is his ECG, and he is discharged completely from the clinic later. So Another case to share is a 3 weeks old referred from family doctor because of lethargy, poor feeding since 12 hours back. Her vital signs were stable apart from heart rate of 200 beats per minute and borderline blood pressure. You can notice it is a wide complex tachycardia. First, if you find something like this, give the diagnosis, take it serious. And the differential diagnosis, it will be FETAC in the top of the differential diagnosis. So patient was intubated, secure IV line, amiodarone infusion was started since the blood pressure was okay. No response to for 1 hour. Then with the amiodarone infusion, then synchronized cardioversion was given, and the patient returned to sinus rhythm. Transthoracic echo was done and showed normal function, normal structural heart, and there is no evidence of ventricular hypertrophy or masses. MRI is crucial for this patient to rule out cardiac fibroma. This case is a 3 days old boy, infant of diabetic mother with birth weight of 4.5 kilogram, admitted to the NICU for observation. Suddenly he developed tachycardia with heart rate of 300 beats per minute, and while the baby is stable. So this is the ECG. You can notice it is narrow complex tachycardia, regular, and you can notice here just at lead 5, V5, there is a retrograde B wave. This gives you a hint that it is concealed accessory pathway or atrioventricular reentrant tachycardia. As I mentioned, atrioventricular nodal reentrant tachycardia is very rare and reported cases. We did give adenosine, and you can notice it is a wide QRS morphology with short BR interval, giving the diagnosis of Wolff-Parkinson-White syndrome or manifested accessory pathway. And this patient, most likely, he will need in the future AV study and ablation. When he is amenable for that, usually we are doing it at the age of 5 to 6 years, or just cut off weight between 15 to 20 kilo, according to the according to the experience of the electrophysiologist. He is doing these cases, and unless the patient has significant malignant tachyarrhythmia between his diagnosis and time of ablation, you may get it earlier for ablation. Last case, just she's still with me in the ICU. This is a 2 weeks old boy for primary gravida mother, presented to the emergency room with poor feeding, and vital signs showed borderline blood pressure and heart rate in the monitor is 250 beats per minute with wide QRS morphology, and was converted to sinus rhythm with synchronized cardioversion. This is the ECG. You can notice it is normal sinus rhythm with normal B wave morphology and normal BR interval. So we take this patient for further investigation and management. So echo done and showed diffuse left ventricular hypertrophy with good function and no obstruction and normal anatomy. Patient was referred to us for this reason, the hypertrophy of the ventricle plus the arrhythmia. Weight is 4 kilogram, and mother denied any history of diabetes during her pregnancy and or any family history of metabolic disorder. Genetic screening worsened. Patient then developed narrow complex tachycardia, but degenerate to wide complex tachycardia with stable vital sign, which give us an impression of supraventricular tachycardia with impression with initial good response to adenosine. And you can notice here, this is from the cardiac monitor, which I like those type of any patient in a cardiac unit, either ICU or ward, to be in a monitor. And just this will help us. You can see the degeneration from narrow complex to wide complex tachycardia, which indicates aberrancy rather than a VTAC. And this is the ECG, but he responded well to the adenosine. Unfortunately, it wasn't easy story like this. The baby was started on titrating up of propanolol till we reach 1 milligram per kg per dose every 6 hours. He continued to have breakthrough of the same tachycardia, required to shift it to 2-6 ICU and stay to start him on amidron infusion, unstable sometime, and he required cardioversion at the time that he would not respond to the adenosine. By the way, I like the way that giving the adenosine by one line, not three-way. Three-way is very confusing. I like to give the adenosine while just holding the in the normal saline and to give it as a push. And usual reason for failing giving adenosine is the administration rather than resistant accessory pathway. Patient, it wasn't easy story, and although with the amidron and is infusion dose, still has a breakthrough. I started him in digoxin as a third medication. Luckily now we completed almost the 24-hour or 36 hours with no breakthrough, but this case, it was expected to be difficult from the start, looking for this hypertrophic ventricle. And usually the types of arrhythmia is not easy to treat, and you have a limitation of medication. Flecainide is not a good option unless you are forced to use. Hopefully that it will work with him and to get him out of the ICU soon. So take home message, just most of the neonatal arrhythmia are benign and doesn't require treatment. Most of non-benign tachyarrhythmia can be treated medically and but required cardiac follow-up to decide about future intervention. Complete congenital heart block is the most non-benign bradyarrhythmia and required cardiac follow-up to decide timing of pacemaker implant. Although the frequency of non-benign arrhythmia is not high, the prognosis depends on the early recognition and proper management without panicking, just to recognize these serious issues for those cases. Precise diagnosis and risk stratification of patient with non-benign neonatal arrhythmia is needed to reduce the morbidity and mortality. Thank you very much. And we'll share any question or a discussion from the audience.